Hello, everyone. Welcome to the CTSN live stream. We have an excellent panelist for this session. My name is Tsuyoshi Kaneko from Brigham Women's Hospital. The title of the talk today will be Surgical versus Transcatheter Therapies for Mitral Regurgitation. Is it competing or complementary? So the excellent panelists are the leaders in this field. From the far left, Dr. Mike Reardon from Houston Methodist Hospital, Dr. Gaurav Balawadi from University of Virginia, and Dr. Gilbert Tang from Mount Sinai. Welcome.
Thank you.
So I would like to start the talk from the degenerative mitral regurgitation. I think these are two separate with degenerative and functional MR. So we're going to sort of focus on degenerative on the first part of the talk, and then we'll move on towards a functional mitral regurgitation. So, Dr. Reardon, I want you to start the conversation here. We have a degenerative mitral regurgitation that are more being treated with transcatheter therapies. And of course, the standard therapy has been surgical mitral valve repair. And what do we see in the future of the ratios and kind of therapies that will be provided to the patients that you feel like it's going to change?
Well, the surgical repair and surgical type repairs are not going to go away. It's one of the few things we do where we really cure patients and we return them both to a normal quality and quantity of life. And so what I see as we move forward is transcatheter repairs that more closely mimic what we do as surgeons. Right now, most of the transcatheter repairs for degenerative are cases that we as surgeons really don't want to operate on for a variety of reasons. And I think as we move into new transvenous, transseptal, neocortal repairs like we do as surgeons, I think we'll see an uptick in transcatheter approaches. Clip approaches aren't going to go away because these are people that are at my institution are all screened by me and have been turned down as not a good surgical candidate. So I think that it'll be very complementary to what we do until we get neocortal stuff. Then it'll be somewhat competitive.
Right. Gaurav, what are your thoughts? You've been the leader in the mitral clip, which has been the only device that's approved for transcatheter mitral valve repair.
Yeah, so I think up to this point, I agree with Mike. It's been a complementary, not competing, particularly at centers where there is a robust heart team. I think like all the centers here, that surgeons that do a lot of mitral surgery are heavily involved in the decision-making. And I think even a step further, hopefully more and more centers with the surgeons involved in the procedure so they can see whether they make the right choice. And this is a discussion I have with our structural heart cardiologist, Scott Lim, all the time afterwards. Do we do the right thing, whether it's a surgical decision that maybe didn't go as well,
right, or
a decision to send the patient for a catheter-based approach, whether it's mitral clip or maybe something that might be more like a replacement or something like that. So being critical of each of the team, making sure we did it right, doing it together, I think that's going to keep it complementary. I think we are on the forefront of competition. As you know, there is an intermediate risk clip, mitral clip study called Repair MR that's, I think, going to be actually revealed at this meeting by Dr. Pat McCarthy, the PI. And there's a lot of thoughts among surgeons. Is that the right approach? Is it the right time? And I think Michael's on the ball also with, there are other technologies. This is the first tool in the toolbox. Industry and patients are driving this. Patients want, they want less invasive. I think if I needed something, I'd want the least invasive so I can continue working and taking care of things. But they're driving this, and we need to really be thoughtful about making sure that the therapy is delivered in the right way. A lot of these new technologies are mimicking surgical techniques, the chordal replacement, annuloplasty. So at some point, we'll be able to do a lot of the things that we do with surgery with catheters.
Right. So Gilbert, you practice in a really world-renowned center for mitral valve repair, as well as transcatheter mitral valve repair. So how are you guys picking the patients for transcatheter repairs at this point of time?
Well, first of all, remember transcatheter mitral valve repair only addresses the mitral valve. It doesn't address other concomitant diseases a lot of these patients have, such as atrial fibrillation, or tricuspid regurgitation, or even coronary artery disease. So I think it's very important to make sure the patient's symptoms are derived primarily from mitral regurgitation, not other concomitant diseases. Number one. Number two, at our center, all of these patients, like what Mike said, are essentially not a surgical candidate. So that's where we would evaluate them. But more importantly, the results matter. And so we really look at the anatomy of the valve to see whether you can actually get down to 1+ or less MR, almost like a surgical results. And if not, then you have the question, was high-risk surgery, which we do very well in, still an option on these patients? And it's all about patient discussion and heart team discussion. But having said, I want to go back to Mike's point about the chordal replacement technologies. I mean, one of the challenges, as Gaurav mentioned, going to repair MR is that once you put a clip in, if there's recurrent MR, the options are quite limited in terms of addressing this population. I mean, there are some really cutting edge stuff talking about extracting the clip or removing the clip, but they still ultimately end up being a replacement. But I think what ultimately patients want all these transcatheter technologies coming down the pipeline is, can I get a transcatheter option first and preserve all the options down the road, including transcatheter and surgical repair options for primary MR? I think that's really the unknown we're facing right now, because only MitraClip is approved in the United States for prohibited risk patients.
Right.
Can I ask one question? And I agree with what you said. You mentioned if they have the right anatomy for a MitraClip, and I'm curious, since you do a lot and think about it a lot at a site that does a lot of surgery, what are some of the things that you're looking at to say, yeah, this is a good candidate for a MitraClip from an anatomic standpoint? Obviously, the risk is separate.
Right. I mean, there are actually established echo criteria, as we all know, that are published to talk about what the level of difficulty for MitraClip procedure. So number one, how big is the valve? Can you accommodate one or more clips to reduce the MR without causing functional stenosis, which we know can predict adverse outcomes? The second point is, can you get a good result, meaning a 1+ or less? Or you're going to accept a 2+ because this patient, we feel that the relative reduction of, let's say, torrential MR to, let's say, down to moderate would be beneficial. So these comes down to the width of the jet, the location of the jet, and we all know we all look at echoes together with our echocardiologist to determine, is this a reasonable outcome, as you mentioned, on this patient.
So let me flip that question, actually. So what are the anatomy that you would not consider, or you would think that the MitraClip will likely fail? There are some anatomies that are not really suitable for this technology, which is the only one that is commercially available. So, Gaurav, is there any anatomy that you think that MitraClip will not do well?
So it's interesting, and I think we're going to talk about functional MR in a bit, but
Which is the degenerative.
When I first started doing MitraClip, I did not think it would be a great option for the Carpentier 3B, really restricted posterior leaflet, because I always think whether it's a surgical approach or a transcatheter approach, when you don't have a lot of leaflet, I think repair gets harder. And particularly with a catheter, you can't create leaflet. Obviously, surgically, there's some techniques with augmentation. So I initially did not think it would work very well for a very restricted leaflet. Obviously, the co-op data has come out, and we see that there's a shift. So to me, the less leaflet, the more restriction, and obviously that can happen even in degenerative if there's multiple jets or different locations of jets. That to me is oftentimes a challenging patient group. If there are flail segments in opposing segments, A2, P2, or A3, P3, those I think can get very difficult. There are some challenges, at least with the current earlier versions of MitraClip in terms of grasping both leaflets. Those are being addressed with being able to grab each leaflet independently. And
on
so I think
on
the newest generation MitraClip, and that I think will help with some of those cases that in the past might have been more challenging.
Right. Do you have any other anatomy that you think?
Calcium commissures and cremular annuluses.
Yeah.
Those are the things that are going to make it really hard to do.
I personally have not had good experiences with Barlow's, with bileaflet prolapse.
Yeah, and I think there is a fair amount of data saying that those are challenging and they have recurrence. There are rare cases that I think all of us have done where we've actually gotten a pretty good result.
Yes.
And I think the other thing, we're focusing a lot on MitraClip. There are certain cases where it's too hard to repair via catheter and they're high risk. So there's now, as you know, many replacement options through clinical trials.
Right. So before we conclude the degenerative session, Mike, you being the thought leader in this field, so you sort of mentioned it, but in 5 to 10 years, what do you think is going to happen in this degenerative MR field?
Well, I think in 5 to 10 years, we are going to have transcatheter chordal repairs, just like we do in surgery. You really never have to resect a mitral leaflet for degenerative. As long as you have plenty of pliable leaflets, as Gaurav said, you can repair a valve, and you can really repair them with cords. We put rings in everybody right now because all the original pairs were Carpentier repairs. We resected part of the valve. We had to stabilize it, or they come in so late the annulus is already broken. In the future, somebody's going to come in, they're going to break a cord and get moderately severe MR, and we can offer them a MitraClip-like procedure and home the next day, and instead of waiting the average 8 years before they go to surgery, they'll get it done then, because that 8 years that you're waiting to go to surgery, you are doing harm to your heart. And if we fix it early, you're going to stop that harm, stop the cycle. So I think 5 to 10 years from now, we will approach degenerative MR much different than we do now. We'll probably be thinking a catheter approach first. It'll be interesting to see.
Anybody to add to that comment?
I think the field has moved forward a lot. Even the surgical field has moved forward a lot, really, in the last 3 or 4 years with Rakesh's Suri's paper on asymptomatic patients, and if you can repair them, get them sooner. And it's a challenging discussion with patients because many of them don't feel bad. And if you can't repair it, or if there's any risk, then you really shouldn't be offering that patient. That the barrier now becomes a lot lower with a safe transeptal approach that still preserves other options. So I think at 5 to 10 year period, it's very likely that there will be more catheter-based approaches. There'll be more first line.
Right.
But of course, there'll still be complex anatomy that surgeons will handle better than catheter. So
Very
don't worry, you guys will still have something to do in the future.
And one thing also remember is that imaging is key. So you can have the perfect anatomy, but if imaging is suboptimal, I would still go for surgical options.
That's a very important point.
Good point.
So we're going to move on to the functional MR, which is going to be a little more controversial, and I'm going to have Gilbert kick this off. But with the COAPT trial, that really changed the landscape of the thought process of how to treat these functional MR patients. And if you add that CTSN paper for severe MR patients with surgical replacement versus repair, the decision becomes much more complex. And where does that transcatheter mitral valve replacement fit into place? So, since COAPT, what are your thoughts at this point?
Well, I think first of all, what COAPT shows us is that medical therapy does really well up to a certain point. So if most of the patients we see at our clinic actually are not being seen by heart failure cardiologists or being medically optimized. So that's our default pathway. You go send to the heart failure cardiologist, they optimize them, and if they're on maximally tolerated GDMT, then we look at what other options, whether MR is the culprit. Remember, a lot of times, again, it could be atrial arrhythmias or other causes of the patient's symptoms in addition to MR. Having said that, the next point is if the patient is medically or clinically a suitable candidate for transcatheter therapy, then we look at the anatomy, essentially. So you need to look at the TEE to make sure anatomically mitral clip could be an option in terms of reducing the MR. Again, remember the COAPT trial, a lot of patients get 1 plus or less MR, and that's why they do so well. So you have to set your expectations and look at it critically. And then the next point is if they can get a CAT scan, more of us here are in transcatheter mitral replacement trial, we looked at that as an alternative as well to kind of see where they would fit, because TMVR eliminates MR essentially. And that we've seen have excellent outcomes based on the literature. So I think that's kind of the thought process we're going through right now. But we always engage the heart failure cardiologist first and foremost.
Gaurav, how's your surgical practice treating these functional MR?
Yeah, so I would say even in the last 3 to 4 years, the patients that I treat surgically with isolated functional MR has dramatically gone down. I mean, it's less than 5%. Fortunately, the degenerate patients are plenty, but we don't see a lot of isolated functional MR. Obviously, the concomitant disease, maybe aortic disease, or another group of patients, certainly a CABG mitral is another population, ischemics, but another group of patients that we're still treating surgically are those that have pretty severe TR, and we're concerned may not have a good transcatheter option for their tricuspid, because those are still in unknowns in clinical trials. And if they're healthy enough for surgery, obviously they're high risk, then many of those patients we're still offering surgery to address both. So that's probably, in my practice, the most common functional MR patient that I treat is somebody who also has significant tricuspid disease that needs to be addressed, and they're not prohibitive risk. So
are you repairing them or replacing them?
The
functional MR.
So it depends. So as you know, there was some post hoc analysis on the CTSN severe MR trials. The caveat is those were ischemic patients, and so we're extrapolating it to all functional MR, which isn't always, may not be the right thing. We also have data that say that non-ischemics you can repair with an annuloplasty that have better longevity than an ischemic patient, some data of our own. Having said that, there's been some post hoc analysis from the CTSNet trial, and there are certain predictors like a basal tethering, basal aneurysm is what was called, but really tethering of the base right below the posterior leaflet. That seems to be an important predictor. To me, also, if it's really restricted, there is not a lot of posterior leaflet Just when I'm looking at it surgically, I think those you're going to need to probably replace.
Right.
I think in the advent of transcatheter mitral valve and valve replacement, I mean, assuming that the valve will take that long to degenerate, these patients have long enough life expectancy, it's supposed to be a very safe and effective procedure.
Yeah.
So replacement might not be a bad option rather than a poor repair,
Right.
because mitral valve and ring is actually, outcomes have been not good at all.
Yes.
Yeah, I think we're going to see kind of two groups of patients. So the elderly, frail patient, where what we know about mitral clip, it's incredibly safe. Compared to a transcatheter mitral replacement, it's in a clinical trial and it's transapical, eventually be transeptal, but replacing the valve is even transeptally is still going to be a lot more on a patient than a clip. So I think the old frail patient who we're not looking for a 10-year result, a clip's probably going to be okay. In a young ischemic or non-ischemic with a dilated cardiomyopathy, maybe a replacement might be the better approach.
And the clip leaves the anterior leaf in there, which is crucially important in guiding your blood into the vortex. And anytime you replace the valve, it physiologically changes your patient. I think COAP and MITRA-FR, when I was on the podium when Greg did COAP, and it was very exciting, and we all said, well, but one failed, one. I think the biggest thing we've learned is we weren't thinking about functional MR the right way. And looking not just at EOAs, but volumes and deciding what really is severe MR and who we should treat. So the things I learned from COAP was medical therapy really works, and we need to think more carefully about MR and how we grade MR and think about MR and who we treat. I think going forward, we have to push people to treat these patients earlier. They didn't want to send them to surgery because our surgical data wasn't good. And so they only sent them.
It's a big insult to a patient.
And so they only sent them to surgery when we had no other option. And of course, those people didn't do well, so it reinforced the story. I think moving forward, what your generation is going to help us do is learn to get these people earlier, break the cycle. They're dying of heart failure, but we're going to move them back up the curve and give them 10 more years.
Right. So, all three of you are involved in the transcatheter mitral valve replacement devices. So where do you think that will fit into into this armamentarium of treatment of functional MR? I'll ask you first, Mike, since you're heavily involved in the Apollo trial.
Well, I mean, there's going to be a place for this. So there's, in my mind, there's no question MR is bad for you. The question is the predominant bad, or is the ventricle the predominant bad? And if the mitral regurgitation is the predominant bad, and you can't fix it with a repair of some sort, transcatheter surgery, then replacing the valve with preserving the subvalvular apparatus makes a lot of sense. The key is we've got to get transeptal. I've had this argument with other surgeons about whether or not putting a hole in the apex of the heart is good or bad. I will tell you, my vote is it's a bad thing, and we've got to get beyond that. And I think in the next couple of years, we're going to get some good transeptal approaches. As we do, and it becomes safer, then I think we're going to start moving this earlier and earlier, and that's when we're going to start seeing the positive results.
Gaurav, Tendyne has the most experience through transapical approach, transcatheter mitral valve repair, the replacement device. What are your thoughts on the position of these type of devices that replaces the valve?
Yeah, so I think what we're going to see is there's anatomy that's not amenable to a repair. And so
you think that the repair should come first?
I think at this point, we know at least what we can say about mitral clip, as I said, it's safe. It's incredibly safe. But if you can't get a good result, and that's where the heart team needs to be critical about every patient. If they don't have enough leaf, if they don't have the right anatomy, if they're functional and they're very tethered, or they have MAC, which is a whole other group of patients we haven't discussed yet, then I think a replacement's most likely necessary. Picking the right patient whose ventricle is not burned out is important. Obviously, there's the transeptal approach is the holy grail. I think we've learned now from about a decade of trying that the mitral valve is not going to go as fast as the aortic, and so we're having to think about what else can we do. And one of the things with Tendyne that they've employed is they think the tether may have some beneficial effect on the LV, and so that remains to be seen. But I do think there's going to be a role, as Mike said, the less invasive we can get, the better. But the valves are going to continue to get better because industry is heavily invested, fortunately for our patients.
Right. So Gilbert, as a young leader in this field, what do you think is going to happen in 5 to 10 years in this field? Well, we don't have a lot of time, so just make it short. But
very short. I agree that transeptal replacements could be the way to go, and I agree that there'll be probably some kind of risk stratification on the patient, that if they're a higher risk patient, maybe palliative repair would be better. And if they're a younger patient, would expect it to bridge to something else, I think replacement will be the right option. I think a lot of unknowns right now with replacement is the anticoagulation needs, durability, all those stuff still needs to be investigated.
Right.
Yep.
Okay, I think time is up. Time flew by really fast with the excellent panelists here. Thank you very much for the wonderful discussion here. Thank you very much, everybody.
Thank you.
Thank you.
Thank you.